Okay, we're going to get started. Actually, I'm going to give this to you.
Oh, yeah, sure. Absolutely.
Okay, so we have Dr. Jassam is going to speak on PIRA, which is progression independent of relapse activity, and also a little bit about biomarkers, and what you guys can really know in terms of what you can do to really know what your MS is doing long term. Okay, so Dr. Jassam, thank you for being here.
Sure. Good morning. Can you hear me well there? Okay, I don't think we need that then. I'll try to project as well. So I think this is a new thinking about MS that I truly like to talk about more often now, because if you like crime drama, do you know that last bit where they catch the criminal and say how everything happened? That's where we're at now with MS. We started understanding the disease. You know, the debate back in the 80s was MS an autoimmune disease or not? And that debate went on for years. Some people believed it was not an autoimmune disease, and the autoimmune section for MS was just a reaction to a degenerative process. And that's why they thought for years, oh, okay. Is that better? Great. Okay. So what I was saying is that there was an ongoing debate for decades about whether MS was an autoimmune disease or not. And eventually, this discussion was settled when there was genetic information about MS. We did something called GWAS, and people believed more that this is an autoimmune disease by definition. So now we know it's a demyelinating. That's we agree upon. We're losing the myelin. Now, how we use the myelin, when we know it's acquired, it's not something we're born with. We get it. Now, how we get it, it's a different debate, and I'm going to try to tell you in a brief what is the current thinking about how MS happens and why we see all these phases of it. But this is the myelin, and these are all the immune cells that try to kill the myelin. Now, we're trying to understand why the body attacks this. Why doesn't it attack the kidneys, the bones? Why the myelin specifically? And there were theories that the virus that comes and infects us, whatever virus is, has a coat on it that is very similar to the coat of the myelin. That was one of the theories we called antigen mimicry. They look alike, the immune system gets confused, it attacks it. Well, it tends to be a little bit more complicated than this. 90% of the US population are infected by EBV at some stage of their lives. So this is not something that is rare. EBV infection is something we could get in kindergartens, when you're a teenager and try to meet other teenagers. That's why they used to call it the kissing disease. So it's truly not a rare disorder. So why do we only have about 1 million patients with MS and not the whole population has MS? Which means that we have to dig further into the biology, and it seems like those patients who have MS get the infection, and within their biology, there's something that sets that reaction. And within that biology is their genetics, that their immune system is more aggressive, agile, or maybe their immunomodulation. Well, immunomodulation means how your body tries to contain a reaction. So if I cut myself, and I cut any of the audience, not that I intend to do so, we will all heal in different ways, because of our biology is very different. Our nutrition, our genetics, our vitamins, which means that we react to viruses also differently. I can shake out a flu probably in a few days. Somebody else can do it in a day, somebody else in a week. So the reaction to the virus is also different, and it means that those patients who get MS will react differently. And not only that, even MS patients will have different manifestations. Some of them will start with the attack with their eyes, some of them with their spine, some of them will do just well with no disability, some of them will go into disability very fast. So that's what makes people think about, is MS all about relapses? Let me see. All right. So back in the day, we used to lump some MS into relapsing, secondary progressive, primary progressive. It tends to be that new MSologists don't like that term, because MS doesn't understand that. What in MS we know happens is that there is progression and there are relapses. By the way, people with a primary progressive MS can have relapses. They don't start with relapses, but during their course they can have relapses. Secondary progressive MS, once we hit it, we behave exactly like primary progressive MS. So are they truly subtypes, or is it just a spectrum of disease? We now believe it's a spectrum of disease. But there are different stages of MS, and we can flip in and out of those. And that happened because, I think 2013, Dr. Lublin and his colleagues came back with a new definition of MS. He said, okay, forget all about this relapsing business and secondary progressive. Now we know that there's relapsing MS and non-relapsing MS, progressive MS and non-progressive MS. And in progressive MS, it could be active progressive MS and inactive progressive MS. What does that mean? You can have new lesions, inflammation is still there, and you're progressing with it. Or you see none of that, and the patient MRIs are stable, there is no inflammation, but the patient is still progressing. These are probably the most difficult ones that we get multiple questions about. What can I do now? All the medications we have don't work on that subtype. Well, because it shouldn't. And now it's known, or it's actually been known for a while, that probably there are two processes in MS. Process of continuous progression that starts from the very, very beginning. And on top of it, there are the relapses. And now again, I'm talking about that crime scene unfolding. It is now thought that the nervous system cells are probably infected by viruses. And the immune system thinks is coming to do a good job by killing these cells, getting rid of the viruses. And those cells are in a continuous battle against the immune system. We now call it smoldering MS, like smoldering meat. Basically, it's very slowly cooking, very slow inflammation. And every now and then, the viruses win, and now the immune system attack to prevent that breakthrough, and comes a relapse. Some of them, it's beyond the clinical detection. You don't see it. You see an MRI lesion that goes away without you feeling much, and sometimes you see it clinically. So against the notion that relapses are a bad thing, it is now known that if you go and advance in life with MS, relapses are not necessarily a bad thing. It's actually a good thing. So in advanced MS, it is good to have relapses because that means inflammation is still part of your disease. And by attacking inflammation, you're actually delaying disability. But when there are no relapses, the inflammation fire has gone away. That means you're now at the mercy of that progressive course that doesn't have inflammation in it. These are just degenerative diseases. And I'm going to show you a couple of pictures that hopefully will show you that. This is now kind of a new concept in MS that we use to diagnose MS and to monitor it, called the central venous sign. And I think my slides are a little bit in a reversed way in terms of coloring. But we now know how MS lesions form. There's a central venous vessel, though a vein, from which those immune cells get out. And the reason they actually, when you look at the MS lesion, they're round plaques, is because when these immune cells go away, there are cells in the brain that come and surround them to contain them, okay? And if these cells are successful, we call them macrophages, microglia. If they're successful, they combine a rim around those cells, contain them. But inside the lesion, the battle is not finished. There is smoldering inflammation still happening. On the MRI, it just looks like an old lesion. But if you actually have advanced imaging, you will see that there's still chronic inflammation in these lesions. And they can expand and they can shrink. But all of this happens in fractions of millimeters over decades. So that's why you do your MRIs every year and they look the same, at least to the naked eye or the techniques we have. They're truly not stable. Okay, so this is the central vein, and this is how a lesion looks like. This is a vein inside the periventricular white matter. It's the middle of the brain. And you can see that rim around it, that lighter gray thing is the inflammation, and that darker rim here, these are the immune cells that are trying to contain it. And it's a continuous battle between the ring of, we call it the brain vanguard, if you wish, and then the offenders. And that's probably what determines long-term disability in MS. Who wins this battle eventually? And this is just a distribution on how we see now these cells in advanced imaging, how we see those attacks in different ways. And to be very honest, if you take an MS brain and look at it in a gross pathology, you will see that the whole brain is inflamed. It's not only the spots we see on MRI. The spots we see on MRI are just the tip of the iceberg. But the whole brain, there was an old concept called normal-looking white matter and normal-looking gray matter. when you look at them closely, the whole brain is inflamed. But those spots are what we can see because these are probably battlefields. The idea is that even if these are stable in number and shape, that doesn't mean that inflammation is still ongoing, which complicates, again, the way we look at MS. And now we're understanding what is this PIRA, progression independent of relapse activity. People who don't have relapses anymore, their disease doesn't have major worsenings, but he can tell you that 5 years ago I was much better. My walking, my bladder, my thinking, my memory, everything was better. I can tell you when this happened, but if you take me back 5 years ago, I used to do better functionally. These are some inflammatory markers, again, for the central venous sign, but these are some new kind of concepts to look at the central venous sign as a way to diagnose MS, to prevent you from having false diagnosis, and also to look at some of the pathology of MS, which I think is going to be hopefully the future of how we image MS, and we get away of the old MRI techniques, which are helpful, but probably not as good in telling us what's going on. So new thinking in MS, relapses and new lesions, relation to disability is true, but it's not always linear. Meaning that patients who don't have new lesions or attacks can still be disabled, and they're truly non-linear. You can have very few lesions in your brain, but your disability is high, and vice versa. And that's why when you see somebody who's young and agile and having MS for the first time as a diagnosis, they come to the clinic and say, I feel fine, I don't know what you're telling me. You see 20 spots there in my brain, but I'm perfect. I don't think I need to be treated. And the opposite is true. When you see the end spectrum, when somebody's in a very advanced mobility problem, and they say, I don't understand it, I don't have that many lesions. And the doctor's nothing is changing, but I can't walk. So that's why these lesions are probably not all about it.